All right, we're live.
All right, we're back. Thank you all. We've had a little break and now we're back at work. Although we probably were working during break, which is typical for all of us. So, the committee, we heard a great deal of testimony on S120. My suggestion on this bill is to have take a minute and let Jen go through the proposed amendment that I have put up on our web page. Then we'll let's take some time to go through that, and then comments will go through with a kind of a discussion mode if we can. But our goal this morning is then to move S120 over to Thursday. We certainly need more time, and I would suggest that we're not going to be able to pass this bill until Friday. And so for Friday, we have H430. We're going to look at H430 today briefly, and then we'll try to act on 430 as soon as we can, along with some of the other bills that we're looking at tomorrow. So our goal is to pass all of the bills out that we have on our agenda today and tomorrow and Friday. But I'm just restructuring the timeline because we've heard so much new testimony today. I think it will be helpful for all of us to dive into it. And I will say this, we keep getting emails and notes from people wanting us to add things into our budget memo, wanting us to add things into our bills. And, we're full up with information. So, I mean, there's no reason why you can't keep sending things. For those of you who are out in the audience, we certainly do welcome your comments, but understand that our timing is very tight and we'll do just the best we can. And we have another year of our session to cover some of the things that we can't get to this year. So, Jen, hello, there you are. Why don't you?
Just sending the 430 language to Nellie for later.
Oh, good. Oh, good. Okay, great. Thanks. Let's go through the 120 proposed amendment, and then we'll move on to 430 and budget memo.
Okay, great. I will put up that language.
And just committee FYI, I did send you an email about this over the weekend, hoping that you would just have a chance to look at it. I tried to triage some of the more problematic and difficult complex areas out of S132 to streamline that a bit, and then to add some comments in to S120 that has reflected some of the testimony we heard today, but the language certainly is open for further modification, of course. But so, Jen.
Okay, so this is, I didn't put it in as an actual amendment format, but some proposals from Senator Lyons. The first relates to this study committee that she has rebranded a little bit, different name, although did you send me even something else after this that I did not?
I did. I thought that we should elevate its value to commission rather than committee. So I want to call it commission on affordable. I think that's another
okay.
To deal with
it. We can discuss. Because it was of a short duration and comes back with a report, it seemed like a study committee, but you can call it whatever you want. So the change in the findings, a couple of changes. One relates to adding a finding on the cost of prescription drugs. So it says the ever increasing cost of prescription drugs continues to significantly increase the cost of health insurance and limit individuals' ability to access care.
Probably should say care and treatment, because drugs are treatment. But
okay, let me can make changes as we go along. All right, make that in my version. So I've indicated all of the changes in highlight with new language in bold. So again, there's the change to the, whether it's a committee or a commission, but instead of being joint legislative healthcare affordability, it's a committee or commission on affordable, accessible healthcare. So I've renamed that in a couple of places. Then under the powers and duties, the committee shall explore opportunities to make healthcare, including prescription drugs, more affordable. And then under the powers and duties, the second one on the all payer model, looking at the efficacy, taking that out and changing it instead to look at how alignment of Medicaid, Medicare, and private insurance patient care management rules and guidelines affect access to and affordability of care, including access to referrals for extended care, counseling, and social services. And then I think that is it on what has been S120, and then there are certain provisions from S132 that are included, and so I tried to indicate where in S132 those had come from. So the first couple of sections deal with ACOs. The first one here being what had been section 5 in S132 on data collection and analysis. And then I took out the language referring to what the Green Mountain Care Board would do with that information, because those provisions are not in this version. So it would still have the ACO collect and analyze clinical data and report that to the Green Mountain Care Board, but it would not be specifically used by the board to inform other work that they're doing, because that other work is no longer called for. What is now here section 4 had been section 6 in S132, is that language giving the auditor, state auditor, access to the ACO's records. Then I've left a placeholder in here for health insurance coverage for hearing aids. You have the language that you're recommending in the budget memo to be part of DFR's benchmark plan review. Was a little unclear what to do with, what, if anything, to do with the remaining provisions at this time, including you may need a better understanding of what Medicaid currently covers. It's my understanding from them, they think they already cover what the bill would have them cover. So you may want to hear that from them. Then we move to the state health improvement plan. So what is section 15 in S132? And this is where the bill would give specific direction to the Commissioner of Health, and not just the Secretary of Human Services or designee, to be the one to adopt the state health improvement plan and update it as necessary. And then a new section that would be, would have the Commissioner of Health submitting copies of the current state health improvement plan by January 15th, along with any updates to the plan and a timeline for adoption of a new state health improvement plan to this committee and the House Committees on Healthcare and Human Services. Then we have additional reports that come from S132, just renumbered here. So the first is the Green Mountain Care Board report on increases in health insurers' administrative expenses for the last 5 years and how that compares with increases in the Consumer Price Index. Next is, again, renumbered, the section 18 of S132 report requiring the ACO to provide a description of its initiatives to connect primary care practices with social service providers, and have that report come in by January 15th. And also is that we have the primary care visits without cost sharing reports from section 19 of S132. No changes in those. It seemed that everything could take effect on passage, because in the underlying bills, they all took effect on passage. So none of the ones, unless you do something else with the hearing aids or something else, didn't require separate effective dates. And then there would likely need to be a new title reflecting whatever you have in the bill. You want me to take it down?
Sure.
You can discuss. Okay.
Yeah. So committee open to conversation, questions, thoughts at this point? I do want to add one thing. As we were going through the the work that we have done, and I just wanted to remind us that in H315, which has now been allowed to become law, there is support for a JFO to hire a consultant to study the ACO. So there will be that will be what I think we might consider an objective analysis of the ACO.
So the only piece I'm aware of that has JFO hiring a consultant, I think, is around, and maybe Nolan can speak to this, but was around advising the committees on global commitment, the global commitment waiver. I don't think JFO was going to be hiring someone to do an ACO.
The ACO, right, you're right.
Right.
So, but it is tangentially, it is very much related to that work. Senator Terenzini, go ahead.
Thank you, Senator Lyons. I just took a note when we were hearing from one of our witnesses about the S-120 bill, and if it's true, it's a little concerning. And unless I misunderstood, this individual said that S-120 has the potential to increase adult premiums by $1,000 more per year if we increase the Dr. Dinosaur funding. And does anyone have any insight into that?
I think we can find you the report. It was done a few years ago. And if others have other recollections, I'm happy to let you respond.
Yeah, that was in the context of several reports that have been done on primary care, Dr. Dinosaur, and others, and it was in Devin Green's testimony. So there is some specific testimony that, as we go through that testimony, will be helpful maybe to focusing on the goals of the group.
It just seems, I'll read the studies and look into it a little more. It just seems a little counterproductive to what we're trying to do here as we look to expand coverage for children, yet we're saying you're going to have to pay more in your premiums to adults. I don't like the balance. So.
Yeah, and so it's something that will have to be weighed out, risks and benefits. And so I see Senator Hardy and then Senator Cummings. Senator Cummings, were you going to comment on, both of you going to comment on this?
Is the Dr. Dinosaur in this bill? No, that's in another bill.
I think it was the study piece, analyzing if that expansion would be a route to take for savings. And so then the comment
But that's a
was,
study. There's no. All right.
Yeah.
So anything we do in this bill wouldn't. I mean.
So this bill does include on the top of page 4 of what we just went over, and in S-120 itself, in number C5, opportunities made available by the Biden administration, it does look at expanding Medicare to cover individuals between 50 and 64 years of age, and for expanding Vermont's Dr. Dinosaur program to cover individuals up to 26 years of age. That's the study.
Right.
There is a link in Devin's testimony. I haven't clicked on the link yet, but it may be a quick way to get you to that report. My general recollection of the rationale behind the cost increases that younger individuals tend to be healthier and less costly, and so removing those lives from the spread risk had the result of increasing premiums. But there's, I'm sure, much more information in that study.
And we are now separating those markets because of changes.
Right, that's the individual and small group.
Yeah. But yeah, if you remove younger, healthier individuals from the pool, the price is likely to go up for everybody else. That's been a constant dilemma. If we add covered services, the price for the remaining services goes up.
So, Senator Lyons, if you don't mind, if I ask a follow-up here, the way this is written right now, this is another study. So if we vote to support it, it's not saying we are raising premiums, not saying we are enacting this or that. This is allowing for a study to happen. And the next step would be for the legislature to take action upon that study.
Yeah, so I mean, there'd
Okay.
have to be a legislative recommendation.
Right.
so you have to, yeah, so many steps.
Okay.
Senator Hardy, go ahead.
Thank you, Senator Lyons. I'm still absorbing a lot of the stuff we heard this morning. It was a lot of testimony, so I'm not sure I can fully
Yeah.
relate or, relate all of it to our conversation. But to Senator Terenzini's point, I think it was Devin or somebody who mentioned that there have been tons of other reports done, and including this one that's mentioned about Dr. Dinosaur. And I think having some reference to those reports, and I don't know how we reference because it sounds like there've been tons of them, but maybe some generic language that just says that the committee shall take under consideration previous studies or something like that. So it's, there's some charge to look back at other things that have been done.
Yeah, I think having a knowledge base built into the committee work makes a whole lot of sense, because people out there don't have a lot of that knowledge.
Yeah, and
Yeah.
there's no need to reinvent the wheel or restudy things that have been studied. So I would support that, and that would sort of get at some of the concerns that I think Senator Terenzini has about, maybe doing something that's already been studied and whatever. Yeah.
Okay, Senator Cummings, follow up, and then Senator Hooker.
I mean,
Just go ahead.
the difference is that there have been changes in DC. And so if I'm reading this, it's to say, okay, we got all these studies, but have recent changes, caused the change in the conclusions. And there will be more changes before we're done with this.
Yeah, this is a really good point.
Yeah.
I think one of the goals of the committee in looking at what's going on is pretty key, absolutely key. Senator Hooker.
And just to follow up, we do have to look at what's happening in DC, but with regard to the reports that have already been done, it'd be interesting to see what recommendations were made and what things have been put into place here in the state, as well as, what's happening now in DC. So I think that there's a real value to looking back, but certainly a need to look at what's happening now.
Yeah, no, I think that is the point. But I think, as Senator Hardy has said, we don't want to reinvent a wheel.
Exactly.
So the goal is to build on what's there. But we, just sort of identifying some of the good work that's been done and whether or not recommendations have been followed up on, and so on. So there's a sense of what we can do to move forward. Okay. Any other questions, comments? Yes, ma'am.
I was just looking at some of the language suggestions that Jessa Barnard made.
Mhm.
She had some specific language, and I had just noted, see her wording suggestions. I'm just looking at them right now, and they might be helpful to consider. That she has changes in the same section. You made changes though, so I don't know if they're consistent with what you were trying to do.
Listen, I heard the same thing, and I think that we should probably give ourselves a little time, and very little time, to go through that. And I wrote down the same thing, Senator. I thought that some of those suggestions might fit. So let's go through. Let's give ourselves that assignment. Let's go through the testimony, and then as we come back to this tomorrow, I'm hoping we can get back to it tomorrow for some time, and then firm up our discussion for markup and vote on Friday. So let's do that. Let's go through this testimony and try to bring some thoughtful recommendations. We don't have to, doesn't have to be a lot, just enough to make it succinct and effective. So, and we don't, so we've heard a lot. So good. Yep. Good suggestion. Committee, does that make sense to everyone? I know no one has free time right now, but can sit on the couch at the end of the day and do some very informative reading. All
I've
right.
been up late the last few nights doing the same with all of our bills. So yes.
I know, all weekend, all day, Monday, it's good. So that would help, and I know each of you has a specific interest. And my suggestion is, can we please make this a committee process? You're going to be inundated with people telling you what to look at and what not to look at. We've heard a great deal of testimony. Let's try to make this a committee process from this point on. And I know there are very interested people out on YouTube right now wanting to influence us and our thinking, and that's going to happen regardless. But I do think if we can make this a committee process where this is a great group of people to do this work. Senator Hardy.
Yeah, thank you. One quick question, and then to your point about this being a committee process, is there value in making this just a committee bill rather than having it the number, since it's a combination? I don't know what the process works right now in terms of, but wanting, saying it's a product of all of our thinking, or
that's a good question for our ledge counsel to answer. So, hello, Jen.
Hi, I think that's really a policy/political question
Oh,
for you.
darn.
Yeah.
Okay, I'm happy to make it a committee bill, whatever.
I
the
mean, either
committee
way,
wants to
you'd
do.
still, either way,
doesn't
it has
matter.
not met crossover, so
right,
I don't
exactly. So
think it
know about
matters.
that.
I
Yeah.
know it's going to be a heavy lift regardless, but so I'm happy to make it a committee bill as long as we can get to a place that we're all happy with. That's fine.
Yeah, it's more for your point about it all working together kind of thing. But my other question is specific to the hearing aid section. Jen mentioned when she went through the bill, whether or not the stuff that we are recommending to be put in the budget would sort of take care of the first steps of that, or if there's more that should be added to this. It seemed to me like what we did there might move us
Cover
down
it?
that road.
Yeah, I think you may be right. And Senator Cummings, did you want to add something?
No, from conversations I've had, it sounds like that the benchmark would be the way, because if we add it, then we have to pay the additional cost with state funds.
Right.
If we say it's a required coverage and
Okay.
it's not in the benchmark. So I think that's the best place to have the discussion.
So, and Jen, is there anything else? I'm trying to remember, there were 3 sections, and I know is there any one of those sections that we might keep, or should we just say the benchmark work is doing its job?
Well, what I can tell you is what's in the bill right now. So what's in the
Okay.
bill right now is, or in the S-132, sorry, there's nothing in the language we were just looking at except the placeholder, is the section 12 of S-132 has the coverage for in the large group market, also Medicaid and state employees and teacher plans.
Mm-hmm.
Section 13 is the application to change the benchmark plan. So it sounds like you've wanted to wait on that until you've had the benchmark plan analysis. And section 14 is directing the Agency of Human Services to seek approval from CMS to provide the coverage that is called for in section 12, which, as I said, they have indicated, at least to me, that they believe they already
Right.
cover, and so that would be unnecessary.
So I think those 3 sections are probably unnecessary, given the work that the DFR is doing and others on the benchmark plan.
Right. So I think the policy question for you is whether you want to enact the large group requirement now, or if you are looking to address it in all of health insurance at the same time after the benchmark plan review.
Senator Cummings, go ahead.
Okay. do we have any analysis as, I'm assuming these are the non-ERISA, so essentially state employees and the teachers.
And right, and the commercial large group.
Okay, that's spot. Do we have any estimate on impact on rates?
I
don't think so.
I don't know if, I mean, it's an actuarial question, so I'm not sure if Nolan has heard from any of the carriers or the state employee plan administrator.
There has been some conversations about what the impact would be, but I don't have anything that I can provide you at the moment.
Yeah, I know the
impact.
insurance companies were interested in testifying, and they are submitting some testimony in writing, but this conversation might sort of obviate the need for that.
But to Jen's, or maybe Senator Cummings' point, the state impact would be the state employee plan.
Yeah.
And I've heard enough from teachers about they have high deductible plans at this point. I think everybody wants it, but I'm not sure they want it to the tune of having their premium go up $1,000. I'm not comfortable doing it without knowing.
No, and I agree with you, and I think if we wait for the benchmark plan analysis, that will help us make decisions going forward. And it's not just this committee, it's obviously your committee that's very much involved. So my suggestion is to take those 3 sections out, but that doesn't mean we aren't very supportive of hearing aids for our citizens, regardless of age and income and coverage. So
Just for the record, I don't see anything that would make premiums go up $1,000 a year.
I was just throwing that out. I have no
Oh, okay.
idea.
Okay.
That's when I'll start getting lots of emails.
wait, you're influencing our thinking, Senator. Okay, does that make sense to people though, really to, I hate taking hearing aids out because I think they're so important, but we have that language that we're,
Will the benchmark study also give us any information about the other plans, what it might cost for the other plans to add hearing aids?
It's going to be specific to the exchange,
benchmark.
well, to the
Yeah.
individual and small group markets, because that's what the essential health benefits applies to.
Uh-huh. So maybe,
I-
go ahead, Nolan, sorry.
Well, I think I would recommend you talk to Blue Cross Blue Shield MVP because I believe that they have done their own internal estimates already. I don't want to get ahead of them.
Yeah, I think both, and they both, if we want to continue and add something in about having that analysis, then we should have them in to present.
Right. You would also
And-
probably want to hear from DFR because I don't think that's within the scope of what they have requested the federal funding to do.
Right.
It's
Right, but could
specific-
we ask the private insurers to do that analysis and report back to us?
Sure, we could just ask them and they probably have already done the work.
Yeah.
Yeah,
I think we
mainly
should-
'cause if we get information about the small group exchange or exchange programs, and then we get information about the others, then we have it all together to look at and make a decision for everyone next session, right? That's
Sort of.
I'm sending you emails about it already.
probably,
Have Blue Cross in and MVP in before we make this decision.
I think we need to do that. So I think that we'll ask Sarah Teachout and Charles Storrow, they represent their respective companies, and they have contacted me, and I will, Nellie, did you think they would not? I think it's great. Nellie, let's try to get them in first thing tomorrow morning. Hopefully they're available. not the first thing because we have people on, but the second thing somewhere tomorrow.
You may also want to hear from Cigna, as I believe they have some of the large group insured market.
Okay. Who's the Cigna representative at this point?
Jen Kennedy.
Oh, Jean. Okay, good. All right, let's do those three tomorrow, Nellie. And asking them for written testimony that we just, they understand the gun that we're under, the time frame we're under. So if we can get their information in writing and then they can come in briefly. The sooner we get the information, the better. That is a message to the YouTube world. Please get us what you have. Okay. That's good. I think that's a good place to end the discussion on hearing aids. Anything else?
Getting back to the S120 draft that we'd looked at, I have at least for now put in an additional item under powers and duties. I'm a new 5 and I moved 5 to 6 to say, so this would be the committee shall consider the following: the findings and recommendations from previous studies and analyses relating to the affordability of healthcare coverage in Vermont.
Excellent.
And I hope that addresses the
Excellent.
issues raised. Okay.
All right. Okay. Anything else? Slowly but surely, we're going to make some progress. All right. So this is our goal tomorrow. We'll find some time. Nellie and I'll, however it happens, we'll put S120 up and we'll have the insurers come in and hopefully they'll get us some written testimony prior to our meeting tomorrow. Then I'm also going to suggest, while we're just talking about tomorrow, please do read through H210 again. And there are a couple other folks who have asked to testify. They'll be testifying, but that's going to be very brief testimony. And then we'll be talking about H210. Then we'll also be looking at S120. That'll be next in line. And then we'll try to finish off our work on H46 and H104. So that means to do a little bit of reading on those bills and thinking where we are on those bills. And then today, right now, Jen, I'm going to ask if you would please take us through H430. And I know there's been some, you've done some great work with DEVA on this to help clarify what can and should or should not happen in the bill. So maybe, I think, put up the proposal, the suggested changes that DEVA was offering, and then explain the reason why we have that, please.
Sure. And Nellie has it posted, I think, after some technical difficulties. So if you may need to refresh again,
Okay.
but I will put up the language. Let me know when you're ready.
All right, we have draft 2.2 up.
Great.
And this is the one that you have in front of us. So Jen, go right ahead.
Great. This is H430. This is expanding coverage under Dr. Dinosaur, although as we'll look at, it's really similar to Dr. Dinosaur for individuals who are not eligible for Medicaid because of their immigration status. And I did work collaboratively with DEVA in coming up with language that they think will more appropriately meet the stated intent of providing coverage to individuals who are, we had referred to undocumented immigrants or people who were not eligible because of their immigration status. And the issue with that is that it potentially requires a full Medicaid eligibility determination with a denial based on immigration status in order to then provide this coverage. So in trying to allow for a more streamlined process to determine eligibility for this particular benefit, I have moved it to a different part of chapter of title
33.
of chapter 33 in the same chapter, but a new subchapter that I've just called covered for additional populations. And this would now be Dr. Dinosaur-like coverage for certain Vermont residents. Because if we call it Dr. Dinosaur, it suggests they'll be on a program, which is a Medicaid funded program. This would be state dollars only. And so we're creating, but just for, I wanted to keep, if they thought it was okay, I wanted to keep this reference to Dr. Dinosaur because I think it's helpful to the rest of us in understanding what's contemplated.
Good, that sounds good. Darn, I was looking forward to having some creative name, but that makes a lot of sense.
So yes, open to other suggestions, but
Oh,
that's why,
just
at least
fine.
for
We
now.
like Dr. Dinosaur like.
So as used in the section, the term Vermont residents who have an immigration status for which Medicaid coverage is not available includes migrant workers who are employed in seasonal occupations in the state. That had been something that was a priority for the House Committee, the Healthcare Committee. And then it requires the Agency of Human Services, and instead of saying requires them to provide Dr. Dinosaur, because as we discussed that in operation would not be quite how it worked, shall provide hospital, medical, dental, and prescription drug coverage, which is all of the coverage in the Dr. Dinosaur program, to the following categories of Vermont residents who have an immigration status for which Medicaid coverage is not available and who are otherwise uninsured. So this is children under 19 years of age whose household income does not exceed 317% of the federal poverty level, and pregnant individuals whose household income does not exceed 213% of the federal poverty level for coverage during their pregnancy and for 60 days postpartum. So this description here of who is eligible and the income levels are aligned with what is offered in the Dr. Dinosaur program. So the incomes are 312% with a 5% disregard. That's how we get to the 317, and 208% with a 5% disregard. That's how we get to the 213 for pregnant individuals. And then it allows AHS to adopt rules under the Vermont Administrative Procedures Act to carry out the purposes of the section. And then the remaining provisions are making conforming changes to use that new terminology and the new location where the language would be codified. So it still has 1.4 million in one-time funds to the Agency of Human Services in FY22 for grants or reimbursements or both to healthcare providers for delivering healthcare services during FY22 to children and pregnant individuals who, and instead of saying are undocumented immigrants, we say who have an immigration status for which Medicaid coverage is not available. And I want to pause there for a moment as well. I should have mentioned under the undocumented immigrant piece, using that terminology, Diva had concerns that there were other types of folks who were not eligible for Medicaid because of their immigration status, but were not undocumented immigrants per se. And these are things like the, and I'm not going to get the numbers right, but the H-1 agricultural worker visa program. Those people are in the country legally, but they are not eligible for Medicaid because of that is not an immigration status that makes someone eligible for Medicaid. So that was a big part of moving away from this undocumented immigrant terminology and referring instead to immigration statuses for which Medicaid coverage is not available. Then so still now back to this 1.4 million in FY22. It's also for grants to Vermont organizations that work with members of, and I kept this language here, Vermont's undocumented immigrant community, because it still seemed reflective of the types of organizations that you would be looking for, but I'm open to other language there, or with members of the healthcare provider community to provide outreach and information about opportunities for children and pregnant individuals in Vermont who, and again, changing this language, have an immigration status for which Medicaid coverage is not available to access healthcare services at low or no cost in FY22 and thereafter, and implementing the technological and operational processes necessary for DVA to administer the coverage for Vermont residents who have an immigration status for which Medicaid coverage is not available, as set forth in this recodified section beginning on July 1st, 2022. And then in section 3, still asking for this estimate, but calling this Dr. Dinosaur-like coverage rather than Dr. Dinosaur coverage expansion. And so requiring AHS to provide information on the estimated FY23 costs of providing coverage to Vermont residents who have an immigration status for which Medicaid coverage is not available pursuant to 33 VSA 2891, beginning on July 1st, 22, as part of the agency's FY23 budget presentation to the various committees. And then in the effective date section, section 2 is the same, subsection A is the same, subsection B, again, making this language change and the codification change, keeping the language about subject to appropriations for the purpose. And then renaming the bill, and I'll put this in proper format if it's an amendment, but renaming the bill to an act relating to expanding coverage for spending eligibility for Dr. Dinosaur-like coverage to all income eligible children and pregnant individuals, regardless of immigration status.
Terrific. Yeah, and with the explanations going forward, and there is time here for some fiscal analysis. It doesn't go into effect right away, so that's helpful. And just in terms of the administration of this, that which was a question that I was going to ask. Oh. And I just have to share with folks, because this brings back so many memories to me about my work with migrant workers years and years ago, and have continued somewhat, but in establishing not just a migrant care program for kids, but a family clinic, and going around and taking people to the hospital, and then accessing a physician or two to provide immunizations and take care of kids and families. And eventually we established a clinic for these people. And today that clinic has expanded from one area, farming community area, to cover, I think it's the whole county, a huge county in New York. But so this could be the beginning of something good, is what I'm saying. Never know. So anyway, questions for Jen?
Jenny, can you see me?
Senator Cummings does.
Okay, can't see you, Senator.
Okay. I can
Okay, I can see me and I can see you.
All right.
Vermont resident, is that term going to give us any issues? If you're talking about people in on a farm workers visa, they're here for a month, 2 months to harvest apples.
It's my understanding from DVA that their rules address Vermont residency and are fairly broad in their interpretation of it, while still requiring some kind of a physical presence here.
Okay.
So there, later on in the bill, you said there is the seasonal folks. And so,
Right, that's right here in the beginning. It includes migrant workers who are employed in seasonal occupations.
so they are considered by Medicaid residents. I'm trying
That's my
okay.
understanding. That they showed me in their health benefit eligibility and enrollment rule, there's a quite extensive description and definition.
Okay. Good question, Senator Cummings. Any other questions? I can't see you, so if you have a question, please speak up.
Okay, this is Ruth. I had sent Jen a few comments last night, and I can go through those. There were two pretty minor and one that I needed Jen's advice on.
Go ahead. Why don't you find the place in the bill? Jen, would you know the spot in the bill? And
Yep,
we
I
can
think the
look at-
first one is right here. So I figured I'd just
Okay.
leave this language right up.
Yeah, that first one is right there, to just add seasonal and agricultural occupations in the state. And the reason is I'm from Addison County, and we have lots of dairy farms, and dairy farm workers are not generally seasonal because you have to milk cows all year. So I just wanted to add that to make it clear it covered those workers in the coverage.
But it says includes. The word includes means that that it goes beyond that. So
Yes, absolutely. That's meant as an addition to, to the extent that there would be a question about residents, that migrant workers who are employed in seasonal occupations would be considered
Oh, I
to
see.
fit this definition. So we could certainly say includes agricultural workers and migrant workers who are employed in seasonal occupations in the state, if that's a concern or of interest. Otherwise, I think this underlying language includes the people that you're talking about who are here year round.
Okay, I understand that includes now is about the temporary status of residents rather than okay, that's fine. And then further down in paragraph 2, I believe, on page 2, and this is about the outreach and information, and I just was hoping we could add culturally and linguistically appropriate outreach and education, just to make sure that when it's necessary, that it would be done in Spanish or whatever language is appropriate. I know that this is often a challenge for state government, and so wanting to make sure that that is covered. This became a really big issue last year at the early part of the pandemic, when a lot of the information about COVID was not translated yet.
yes, it was. And yes, and Department of Health, we added language in some of our bills around this. So how would you say that, Jen? It should be related to culture and language, or simply language? Culture probably is important.
Yeah,
Right. I think Senator Hardy's recommendation of culturally and linguistically appropriate outreach and information seems to work.
Good.
If that's what the committee is interested in.
Is anyone on the committee not interested in adding that? Okay, so let's do it.
Okay. So that I put that in my actual draft.
Thank you. And then the final one, and this was what I needed your advice on, was some kind of guarantee, or at least assurance of confidentiality. This was something that we had included in the bill that we did about the stimulus equity payments last year that started in Senate Agriculture Committee, and was a big concern about that, to make sure that this information would not then be shared with the federal government and cause deportation or any problems like that. So I don't know specifically where it makes sense or what the language should be. I believe Mike O'Grady had something in that bill. But Jen, I would defer to you on your expertise on that.
Well, I'm looking up, I know there are some fairly significant confidentiality provisions around Medicaid itself. And I just wanted to look at, there is confidentiality of Medicaid applications and records. And I know we talked about this not being
Not Medicaid, but it's like it.
Right, but let me check in with the DIVA folks. I think maybe just a cross-reference to this provision saying she'll be subject to the same confidentiality provisions as in this existing section 33 VSA 1902A might be sufficient. We could put that right in the statutory section creating this program. And then if you wanted, we could also put something in that outreach.
I think that is a very good addition.
So something like, and the confidentiality of information submitted to obtain coverage, something like that. I'll look at that. Does that sound like what you're looking for, Senator Hardy?
I think so. I just want to make sure we're just able to give people assurances that this wouldn't lead to deportation of them or family members or separation from their kids or anything like that. That is, you know, a very real and understandable fear. And so anything we can do to make those assurances. So if you want to check in with Diva, that would be good. But just want to make sure we're explicit about it.
Yep, I will. Yes, so that would be my thought. Let me check in with them. But I'm thinking adding something in section, or I'll put the language back up and show you where I'm thinking. Actually share it first. So I'm thinking potentially putting in something like a new C here that says the agency shall adhere to the same confidentiality provisions as in section 1902A of this chapter. And then putting something here with the grants. So we already have the culturally and linguistically appropriate going in here before outreach. And then adding something right here at the end that would be, you know, and the confidentiality of any information submitted to obtain this coverage, something like that.
So, so Jen,
Yes.
regardless, even though this is a Dr. Dinosaur-like program, and as with any healthcare, this is HIPAA protected.
Well, this
Yes or
isn't that,
no?
this, I don't know how to answer that question. This isn't treatment. So there are confidentiality provisions that apply, but I'm
Okay.
not sure the extent to which it's specifically HIPAA in an application for coverage. So I don't know how to answer that question.
Okay, so forget I asked it, but I think that we should add the pieces in that we've been talking about here.
And I'm thinking maybe just to say in the confidentiality of information provided by applicants, something like that. Applicants and enrollees, I guess.
Right.
Or regarding okay, yes, I will work on that language in consultation with the DIVA folks.
Thank you.
Sure,
Perfect.
thanks for raising it.
Yeah, no, those are good. Those are good things to add into the bill. So let's do this then. Let's, this is Senator Hooker. Did you have a question?
Alliance, yes, thank you. Just a small point with regard to the renaming. Jen, you have for expanding eligibility, but is this not a new program? Would it be more like
Just plain
establishing
eligibility, right?
eligibility rather than expanding, since it's not really connected to the
You're talking about the new title?
correct.
I think that's a good point. Yep, I will take it out. Just eligibility for Dr. Dinosaur-like coverage for all income eligible children and pregnant individuals, regardless of immigration status. I think that, thank you. That's a good.
Yeah, so keep your eyes open, go through the bill again, and Jen will bring back language for us. And this bill we will look at tomorrow, I think, rather than Friday, to try and get it, out, along with H210, 46 and 104, and anything we have that spills over to Friday. I'm pretty sure 120 will be, we'll talk about it tomorrow. I think that we'll probably finish it on Friday, just the timing of it all. Okay, thank you. That's great. Making huge progress. Jen, so let's take a look at the budget memo yet again. And I
Great.
did make I forgot something, so you'll have to help us
Okay,
the 105% of Medicare.
right. So I
for,
put that in.
primary
I
care.
wasn't sure. I put it in under additional proposals for consideration because I don't think you have a dollar,
Heck,
unless you
no.
have a dollar amount.
No,
Okay.
no, we don't.
All right. Well, I will just for now put the language up. And then when we have it finalized, I can send it to Nellie. So the only two changes, I think, since we looked at it earlier, as I've highlighted them to make it easy to find. For additional one-time appropriations, we have $25,000 to the Vermont Donor Milk Center to provide Vermont infants and their families with access to pasteurized donor human milk, which is the term that they use. Does that look like what folks were expecting?
That looks good to me. Thank you.
Sure. All right. And then down here under additional proposals for consideration, I put in consider increasing Medicaid reimbursement rates for primary care services to 105% of the Medicare rate.
Yeah, that's been an ongoing issue, and it does help to promote primary care in the state. But the question is, what's the fiscal note on that one? So we're not adding in the fiscal note. We're just putting it in as a recommendation, and if we can find the dollars for that, I think that would go a long way, both to keeping primary care docs and others, APRNs perhaps as well, but in the state, and actually attracting more. So does anyone not want to put that one in? Let me know now. Nolan, you have your hand, want to put it in?
No, that's not why my hand is raised. Of course-
Go
of course.
ahead. I can't see you, so you have to speak up.
So I did a little bit of work for this for Senator Hooker, and I did have an estimate. If you
Cool.
want me to talk about it.
Absolutely.
So I'm just reading my notes here. So DEVA does have a program where they attest that the provider is board certified primary care provider. So that's an enhanced primary care program. These providers already receive 100% of Medicare for their identified primary care codes. So to increase, and so this is so to increase the rates for primary care codes for these providers to 105% would be $1 million gross. Now, the reason I highlight that is because it would be increasing it for people who have been identified as a primary care provider versus just using a primary care code. If you just increased it to 105% for primary care codes, regardless of whether people are part of this enhanced primary care, so they might be like a non-primary care person using a primary care code, then that number is $8 million. So I think that one way to specification you could say is increase primary care codes to 105% for those board certified primary care providers who are participating in Medicaid's enhanced primary care program. And that would be $1 million. So you could be specific, or you can, so that's just, and by those estimates are based on the 2020 primary care rates. So it'd probably be a little bit more than the $1 million, but that's
Yeah.
your sense.
Is there a way, do you think there's a way to have both of those in? So as an or, I mean, one's an umbrella, the $8 million, and then the other one is greater specificity.
I think that if you say increase primary care rates for primary, to 105%, and just leave it as it is,
Okay,
it's unclear,
yes,
could be as much as $8 million. If you
okay.
want it to be clear, you could be more specific.
Yeah, I think it does make sense to leave it as it is, because then there's some decision making that can go on based on what funds might be available. Go ahead, Senator Hardy.
Thanks, Senator Lyons. I actually think we should be more specific if we're going to include this, because our goal is to help primary care providers themselves. These codes could be used by any kind of provider just that is doing something that would be coded as a primary care service, is my understanding, if I'm understanding Nolan correctly. So it could be like a podiatrist, not to pick on podiatrists, but who might be doing something that would be coded as primary care. But if our goal is to really focus more dollars to primary care providers, then it would seem to me that we would want to be specific about it. And then it's cheaper also, but that's, I mean, this is benign. We're just including it in a list to consider.
So
So
if we, but you're right, if we put it in and it's with specificity, it is cheaper. So then when the question is asked of Nolan, how much is this going to cost us? Oh, it's $1 million. Maybe that's,
Actually, and you can be more specific, you can be $1 million gross, 440,000 general fund.
yes. Okay. So, okay, so Senator Terenzini, any thoughts on this one? Senator Hooker, he's good. He's got his thumbs up. Senator Cummings.
I like the more limited.
Okay, let's do it then.
Are you looking for this and you're still in the additional proposals for consideration, or do you want an additional one-time appropriation dollar amount? Or
I think it's in our
Well,
wish, it's
it's
more,
it's in the additional proposals?
yeah,
Okay.
I think it has to be at this
And
point.
so what was the language for the narrower version,
So-
Nolan?
And again, and just to clarify, this is I'm explaining it in the way that it was explained to me. So I hope I did it justice how I explained it. Maybe you'll hear
I'm
from
sure you did.
the medical society being actually, but so I might say it, 105% of Medicare for board certified primary care providers who participate in Medicaid's enhanced primary care program or something like that.
Can you say that again, please?
To 105% of Medicare for board certified primary care providers who participate in Medicaid's enhanced primary care program. And maybe Nissa's listening and she'll send me an email clarifying a better way of saying that, but
I was just asking to have you repeat it because Jen is typing away,
Thank
Yeah.
you.
entering data.
That's great. Okay.
and then you could say it's $1 million, estimated to be approximately $1 million gross for 440,000. Well, see, but that's 2020 rates, so it'll be a little bit more. But so I just say approximately $1 million gross for $440,000 general funds based on 2020 Medicare rates or something like that. Estimated to be something like that. And then I can work with Stephanie if they were to do that on a more specific number.
Okay. Well, it's on the list and now we have an understanding of what it is and I guess Nolan, does the phrase board certified come to you from DEVA or do they need to be board certified? I guess is my question.
Right. I think that's quite a subset.
Yeah, that is.
You're muted, Nolan.
If they're participating in the,
Yeah. So what you sorry, I apologize. I was muted. So
Oh.
you're right. I think you were about to go down that road. You can just say physicians participating in the enhanced primary care program. Because
So when you say physicians, do you really mean physicians, or because we had primary care providers and that's
providers who
okay.
participate in Medicaid's enhanced primary care program. And yes,
Okay. Do we keep them as primary care providers, or it doesn't even need to say that if they're participating in the Medicaid enhanced primary care program?
I'm guessing that if
I think primary
they have to
care,
attest that they are board certified. So I think you're right. You don't have to say that. You can just say participate in.
All right. But Senator Lyons, do you want to keep it as primary care providers who participate in the Medicaid enhanced primary care program?
yes.
Okay. Standard. Oops. Okay, so
What does it look like?
uh
Oh,
yes. State. All right, let me put this back up for you. Give me. Sorry, school vacation week.
Grandkids are coming this afternoon.
Oh, goody.
They
And
were
you
here
know,
the last 2 days.
they're going to have fun playing out in the snow, Senator.
Uh-huh.
All right. So here's how I revise that. Consider increasing Medicaid reimbursement rates to 105% of the Medicare rate for primary care providers who participate in the Medicaid Enhanced Primary Care Program. The estimated cost is approximately 1 million gross, 440,000 state based on 2020 Medicare rates.
Okay. Committee? Senator Terenzini, Senator Hooker, Senator Cummings.
Good.
Okay. All right.
Great.
Senator Hardy, I know you're fine with it, I think.
Yep, looks good to me.
Okay. All right. So are we fine with our memo? This memo has taken its toll of time.
Will it be posted on our page or what's the, yeah.
I think so. I mean, my plan, I didn't want to keep sending,
Yeah, I
Uh,
think we
interim
probably need to get it off to
versions, but-
approps and then
yes.
and we'll
But if
post it.
you're good, I will.
Do we need to vote on it? Madam
Yeah.
Chair, or-
I think we just, we don't usually vote on it. We just all agree that this is the memo we'd like to send. So is there anyone who is not interested in sending the memo? Then we'd take a vote, I guess. We're good. Thank you for all your hard work on this. This has been good work.
So
Are
do
we
you want me
fin-
to send it to you to send to appropriations? Do you want me to send it to appropriations and copy you? How do you want to do it?
How do we usually do that?
I don't know.
Just send it.
Depends.
It's
Okay,
fine. Send it on my behalf and on the behalf
Sounds
of the
good.
committee.
will do.
All right. We're good. Okay, and it's the precursor to all of these money bills that we're sending out, so they'll get a flavor for what's coming. All right, so tomorrow I'm going to work with Nellie a little bit on restructuring the agenda, but we will start out with S210. And I know that there are people who keep asking to testify, and so I keep getting people asking if they can testify, and the answer is we'll make a decision based on the time that we have. But certainly anyone who is very much interested in S210, because it is an important bill, should please submit some written testimony. And if you have suggestions for improving the bill, that's good. But I also want to warn us that, we want this bill to go forward. And we're going to, if there are differences that the House can't tolerate, we'll have a conference committee. So we do want to make sure that the bill is as effective as we can get it. So we'll keep working on that one. And S104, H104, H46, S120, H430, we're all on our agenda for tomorrow. So we're good. I'll see you all anon.
Okay, we'll see everybody. I'm on my way